Undifferentiated Connective Tissue Diseases, a Practical Clinical Guide. Hello and welcome. Today we will explore undifferentiated connective tissue disease, or UCTD, a clinical challenge that all clinicians caring for rheumatology patients will encounter. This session explains what UCTD is, why it occurs, how to evaluate it step by step, how to manage and monitor patients, and when to escalate care. The goal is to make the uncertainty manageable and clinically useful. Definition and clinical context. Undifferentiated connective tissue disease describes patients who have features suggestive of a systemic autoimmune connective tissue disease, symptoms, signs, or autoantibodies, but who do not meet established classification criteria for a specific disease such as systemic lupus erythematosus, systemic sclerosis, dermatomyositis, or rheumatoid arthritis. In short, the patient looks autoimmune, but the pattern is not yet classifiable. Why this matters? UCTD is common, especially in early disease. Early recognition prevents missed organ-threatening disease and allows appropriate monitoring without overtreatment. Epidemiology and typical patient profile. UCTD is most often seen in young to middle-aged women, though it can occur at any age or sex. Many patients present with nonspecific systemic symptoms such as fatigue, arthralgia, low-grade fever, and Raynaud phenomenon. On average, a proportion of UCTD patients will remain stable for years, while a subset will evolve into a defined CTD over months to years. Understanding the pathogenesis, why UCTD exists. The pathogenesis is essentially the same immunologic processes that cause defined CTDs: genetic predisposition, environmental triggers, breakdown of immune tolerance, and production of autoantibodies. In UCTD, however, the autoimmune response is either incomplete, low-grade, or limited to certain immune pathways. This results in a clinical footprint that is real, but not yet fully developed into a specific disease phenotype. From a practical standpoint, this explains two things. One, autoantibodies such as ANA can be positive even when organ involvement is minimal. Two, the presence of certain autoantibodies or clinical clues may predict evolution into a specific CTD, so careful characterization is useful. Stepwise clinical evaluation approach, UCTD systematically. Step 1. History. Begin with a focused systemic review. Constitutional symptoms, pattern of joint pain, morning stiffness, photosensitivity or rashes, Raynaud phenomenon, dry eyes or mouth, muscle weakness, dyspnea, chest pain, neurologic symptoms, and obstetric history in women. Ask about exposures, infections, new drugs, and family history of autoimmune disease. Step 2. Physical examination. Look for subtle signs: synovitis, non-erosive inflammatory arthritis, mucocutaneous findings like malar rash, discoid lesions, sclerodactyly or skin tightening, nail fold capillary changes, telangiectasia, muscle bulk and strength, lymphadenopathy, and organ signs such as crackles or edema. Even small findings matter because they can evolve. Step 3. Baseline laboratory testing. Order screening labs. ANA by immunofluorescence is a starting point. If ANA is positive, check ENA panel, anti-Rho SSA, anti-ELA SSB, anti-SM, anti-RNP, anti-dsDNA, anti-CCP, RF, complement levels, ESR and CRP, CBC, liver and renal function, and urinalysis with urine protein quantification. In addition, screen for thyroid disease and other mimics when appropriate. Why this panel? It helps identify specific autoantibodies that carry prognostic information. For example, high-titer anti-Rho suggests possible progression to Sjogren's or subacute cutaneous lupus, while anti-RNP can herald mixed connective tissue disease. Step 4. Targeted investigations. Based on symptoms, do targeted testing. Schirmer test, or ocular staining for dryness, salivary imaging, or lip biopsy if suspected Sjogren's. CK and EMG and MRI if muscle weakness suggests myositis. HRCT and PFTs if breathlessness or crackles hint at interstitial lung disease. Nail fold capillaroscopy is useful for suspected scleroderma spectrum disease. Step 5. Risk stratification. Classify patients into low or higher risk categories for evolution. High-risk features include high titer or multiple autoantibodies, abnormal complements, specific antibodies like anti-dsDNA or anti-SCL70, persistent cytopenias, significant organ abnormalities on imaging, or early evidence of nephritis or myositis. Low-risk patients have mild symptoms, low titer or isolated ANA, normal organs, and stable labs. Clinical vignettes that illustrate common scenarios. Vignette 1. A 30-year-old woman presents with fatigue, intermittent joint pains, and a low-grade fever. ANA is positive at 1.320, anti-Rho negative, anti-dsDNA negative, complements normal. Urinalysis and renal function are normal. She has no organ-specific symptoms. This patient has low-risk UCTD. The appropriate approach is symptomatic care, education, and scheduled monitoring. Vignette 2. A 42-year-old man has Raynaud phenomenon, fingertip pitting scars, and a positive ANA with anti-SCL70 antibody at low titer. Pulmonary function tests reveal mildly reduced diffusion capacity. This patient has UCTD with scleroderma features and is higher risk for progression to systemic sclerosis. Early multidisciplinary referral, baseline HRCT, and close lung monitoring are indicated. Vignette 3. A 25-year-old woman with photosensitive rash, oral ulcers, arthritis, low complement levels, and anti-dsDNA detectable but not meeting full SLE criteria. She has evolving disease and requires close surveillance and consideration of early immunomodulatory therapy if organ-threatening features appear. Natural history and prognosis. Most patients with UCTD have a benign course. Many remain undifferentiated for years. Published cohorts show that about 20 to 30% evolve into a defined CTD within 5 years, depending on baseline features. Predictors of evolution include specific autoantibody profiles, high ANA titers, positive ENA subtypes, complement consumption, persistent cytopenias, and early organ dysfunction. Prognosis varies. Low-risk patients often do well on supportive care, while high-risk patients may require early immunosuppression to prevent organ damage. Management principles. Practical and pragmatic. Management is individualized and guided by severity, symptoms, and organ involvement. Principle 1. Treat the patient, not just the tests. Mild, non-progressive symptoms often respond to NSAIDs, short steroid courses for flares, hydroxychloroquine for arthralgia and skin disease, and non-pharmacologic measures such as sun protection and physiotherapy. Principle 2. For organ-threatening features or high-risk profiles, early use of steroid-sparing immunosuppressants such as methotrexate, azathioprine, or mycophenolate may be warranted. The decision to escalate should involve rheumatology and organ-specific specialists. Principle 3. Shared decision-making. Discuss diagnostic uncertainty with patients, explain the plan for monitoring, and advise on red flags that require urgent review: new breathlessness, hematuria, chest pain, new neurologic symptoms, or sustained fevers. When to refer and whom to involve. Refer to rheumatology when there is diagnostic uncertainty, high titer or multiple autoantibodies, organ involvement, or progressive symptoms. Early referral is essential for patients at risk of organ damage. Involve nephrology for any renal abnormalities, pulmonology for ILD, dermatology for unclear rashes, and obstetrics for women planning pregnancy, as UCTD can impact pregnancy outcomes. Monitoring strategy: how often and what to check. For low-risk UCTD, clinical review every 3 to 6 months for the first year, then extend intervals if stable. Check ESR-CRP, CBC, renal function, urine analysis, and specific autoantibodies periodically. For higher-risk patients, more frequent reviews, baseline and follow-up organ imaging as indicated, and earlier escalation to disease-modifying therapy if signs of evolution appear. Practical tips for pregnancy and contraception. UCTD requires particular attention in women of childbearing age. Preconception counseling, review of medications for teratogenicity, and rheumatology obstetric coordination are essential. Some autoantibodies, notably anti-Ro SSA, carry fetal risks such as congenital heart block, so fetal monitoring and multidisciplinary care are necessary. Common pitfalls and diagnostic traps. Pitfall 1. Overlabeling. A low titer ANA in isolation is common in the general population and does not by itself diagnose UCTD. Clinical context is essential. Pitfall 2. Undermonitoring. Dismissing early systemic signs can delay diagnosis of classifiable CTD and miss opportunities to prevent organ damage. Pitfall 3. Misinterpreting transient antibodies. Some autoantibodies can be transient after infection. Confirm persistence if results are unexpected. When UCTD evolves, action steps. If a patient evolves into a defined CTD, management shifts to disease-specific guidelines. Lupus nephritis protocols for SLE, immunosuppressive regimens for systemic sclerosis-related ILD, or myositis therapies when muscle is involved. Rapid communication and updated care plans help optimize outcomes. Communication and patient education. Why this is crucial. Be transparent about diagnostic uncertainty, but proactive in monitoring and symptom management. Provide patients with written information, red flag symptoms, and clear follow-up schedules. Encourage healthy behaviors, smoking cessation, sun protection vaccinations, and explain the rationale, reducing inflammation, preventing flares, and minimizing infection risk. Summary and clinical checklist. To summarize, UCTD is a common, real clinical entity representing incomplete autoimmune disease. Evaluate carefully with history, focused exam, baseline labs, and targeted organ testing. Stratify risk by antibody profile and signs of organ involvement. Manage low-risk patients conservatively with symptomatic care and monitoring. Escalate therapy and refer early for high-risk or organ-threatening disease. Educate and empower patients so that the uncertainty of today does not translate into preventable harm tomorrow. Closing, thank you for listening. Use this approach to make an ambiguous diagnosis clinically actionable. Spot the red flags, stratify the risk, monitor reliably, and involve specialists early when organ damage is a concern. That way, undifferentiated disease becomes a controlled pathway rather than a source of anxiety for patient and clinician alike.